Please let me know. I'm just checking. Okay, so today's session is a very important topic, that is the pleura and the pleural cavity. So we will have the discussion of the pleura first, and then we will discuss also the pleural cavity. So both the topics will go in hand, and it's very important that you should understand this conceptual topic, because so many questions has been asked in the previous year of university exam, and also for your viva and the practical examination. So what all things you have to know. So if I talk about all important aspects which has to be known by you, is that you should know the pleural reflections, you should know the parts of the pleura, you should know about where is the pleural cavity lying, what is the serous fluid lying inside, what is the serous membrane, what is the clinical anatomy, what is the surface anatomy. So many things are there, and also the pleural recesses you have to know. So many things are important in this topic, and we will have the proper discussion of the topic along with diagrams which you have to make, because it's very important that in the university paper it is important that you should be able to make all the diagrams. So we'll make the diagrams also simultaneously. Any of the students is finding any difficulty in understanding any topic, they can write their doubts in the session itself. So in the live session only we will discuss the doubts, don't worry about that. So let's start with this session. So I would like to start with the pleura. So so pleura and the pleural cavity. So basically if I talk about the lungs, so the lungs are lying in the lateral compartment of the thoracic cavity, and each lung is enclosed by a serous membrane, and this serous membrane is having two layers. The inner is the visceral and the outer is the parietal layer. So the visceral layer, if I talk about the visceral part of the pleura, it is attached to the lung surface, and it is actually very shiny and adherent to the lung surface, and it is also adherent to the fissures which is lying on the lung surface, and it lines the pulmonary cavity. And if I talk about the parietal one, it lies the thoracic cavity. So basically, yes, thoracic cavity can also be called as pulmonary cavity. So what it means, that the visceral layer is investigating and surrounding. So basically if I talk about the visceral layer, it is surrounding the lung surface, and it is adherent to the lung surface, it is shiny. And if I talk about the parietal part, it is lining the inner aspect of the thoracic cavity. So in this diagram we can appreciate both the layers. So as I told you, each lung which is lying in the lateral compartment of the thoracic cage is invested by a serous membrane. So here in this diagram, if I slightly enlarge it also, you can see. So what you can see, this is the lung surface, and you can see on the lung surface inner aspect. So if I just use a different color, yeah. So this inner aspect, if I'm talking about this part, let me use blue color for it. So what is this layer? This will be the visceral layer. Okay, this is the visceral part of the visceral pleura. This is the visceral lung pleura, as you can see, and the outermost, let me use another color. So I'm using green for the outermost layer, that is the parietal one. So this is the parietal layer. This is the parietal pleura. Okay, so and if you will, if we can also enlarge it more, so in between this parietal and the visceral pleura, we will have this space. So I'm just highlighting this space is the pleural cavity which you are seeing. This is the pleural cavity. So this is how you can understand. So basic point about these it's very important that you should be also knowing the embryological aspect of how the formation of pleural cavities and that of the serous part of the pleura, which is again the serous membrane is made of two layers, the visceral and parietal is known to you. Is it okay? So the space which is lying exactly between the visceral pleura and the parietal pleura is called as the pleural cavity. What is the function of visceral pleura? It is investigating or invested, or it is surrounding the lung surface, adherent to the lung surface, and that of the pleura, which is the parietal one, is attached to the inner aspect of thoracic or pleural cavity. Okay, so here it is very important for you to understand when I'm talking about the pleural cavity. Before that, each lung is invested by and enclosed by serous membrane, by a serous membrane. And this serous membrane, which is enclosing the lung, is made of two layers, serous membranes. Okay, this is an important point for you to know. This is made of two layers. And what are these two layers? One is the visceral pleura and the other is parietal pleura. And in between these two layers, if I talk about the space, so basically the space which is lying in between, so the space in between, so if I'm talking about the space which is lying in between these two layers, okay, so we are now knowing that this is the visceral pleura, no doubt about that, I have shown you also, and this is the parietal pleura. And the space which is lying between these two, visceral and the parietal pleura, that space is called as the pleural cavity. What is that space, my dear students? That space is called as the pleural cavity. Okay. Now, so basically, if I talk about the understanding of how this happens, so it is important that we should be knowing little about the development of lung and its relation with that of the lung and the pleura. So to that will help us to understand more in detail. So let's talk about that. So let's talk about a little description about the embryonic period. So what happens in the, so I will also make a diagram for it. So during the early phase of embryonic life, so if I talk about during early embryonic life, what happens? The lateral part or the lateral compartment of thoracic cavity is occupied by a closed serous sac. So during early development of the embryonic life, during early embryonic life, the lateral thoracic cavity is occupied by serous sac. What it contains? It contains a serous sac. So basically there is initially only a serous sac, and then what happens? The lung bud develops. The lung bud which develops, that will invaginate the serous sac from the medial aspect. Okay, so it is, if I talk about this serous sac, it is invaginated. It is invaginated from the medial side by the developing lung. And what happens? Because of this invagination, because of this developing lung bud, and because of this invagination which happens in the serous sac from the medial side, there is formation of doubled layered sac. So this invagination will result, this invagination will result, this invagination will result in formation of double layered sac. Now, the so basically what happens? Because of this invagination, there is formation of double layered sac. And actually, if I talk about this double layer sac, the outer layer is the parietal pleura. Okay, and inner layer is the visceral pleura. Okay, so basically the visceral pleura, if I talk about the visceral pleura, it is continuous with the parietal pleura at the root of lung. One of an important point is the visceral pleura is continuous with the parietal pleura at the root of lung. Is it okay? So that means both of it is continuous with each layer. That means exactly, if I talk about the visceral and the parietal pleura, they are separated by a potential space, and that potential space is called as the pleural cavity. Is it okay? The pleural cavity is filled with a thin film of tissue fluid that is important for the lubrication of the lung surfaces and this will help in smooth movement without friction. So, okay, any doubt, please let me know, my dear students. I'm just checking with your messages. Yes, good evening, Abhishek. So, yes, if any of the student is not understanding anything, please let me know. Is it okay? So, this is how the formation takes place. So, basically, for a better understanding, so we could also know the potential space in between. The potential space in between these two layers will lead to the formation of pleural cavity. And what does this pleural cavity contains? This pleural cavity is containing tissue fluid, which is important for the lubrication of the pleura and allow the movement without any kind of friction. So this is an important point which everybody should understand. So for a better understanding, I would like to make few line diagrams so that you can understand how the pleura is formed and how the pleural cavity is formed. So invagination of developing lung into the closed serous sac. As I told you initially, in the thoracic cavity, there is serous sac present just. But because of the development of lung bud from the medial aspect, there is formation of the two-layered serous membrane and the pleural cavity. So let's make a diagram. So the heading of the diagram will be invagination of developing lung into closed serous sac, into closed serous sac. So for that, I will draw one or few steps so that you can understand. So invagination of developing lung into closed serous sac. So we will draw few images so that you can better understand how it happens. So we will draw steps. We will draw few steps. So firstly, what happens? There is just there is one sac on the, if I talk about the first thing which is there is in the lateral space of the thoracic cavity, there is just the presence of a sac. Okay, that is called as serous sac or pleural sac. So I will just draw one laryngotracheal tube like this, and we will draw on either side lung bud. Okay, this is how the process of formation happens. Okay, now this is the first step. So basically this will be the first stage. This is the stage 1. Then I will also talk about the stage 2nd. Okay, in stage 2nd. So basically, let's know. Yeah. Okay. So this structure is laryngotracheal tube. Okay, this is the lung bud. Okay, and this is the pleural sac. This is the pleural sac. Now, in the second stage of development, initially it is like that. When I am talking about the initial stage, if you remember, during the early embryological developmental phase, the lateral compartment of thoracic cavity is occupied by a closed serous sac. So this is pleural sac, which is a closed serous sac. What is it? It is a closed serous sac. And later on, what happens? There is, in the second stage, what happens? There is the formation. What happens? There is the formation of lung bud. So then the lung bud will enlarge. Till now, the lung bud was not enlarging. Now I will make a second stage in which lung bud will enlarge. And this enlargement happens from the medial side, and this will invaginate in the serous sac. So you can see this is exactly how the invagination happens. Okay. Can you see? This is how the invagination happens. So here now what happens? This will be the parietal pleura. This will be the parietal pleura. This is the parietal pleura, my dear students. And this will be the visceral pleura, which is on the lung surface. This part is the visceral pleura. Okay. Subsequently, when the development happens, this was the stage 1 and this was the stage 2, which you have seen. Subsequently comes the stage 3, and now the lung bud has enlarged. So again, you can just shade it. This is the developing lung bud which I have made. And with subsequent development of the lung bud, this invagination which is happening from the medial side will be inside the root of lung. So let's talk about third and fourth stage. So I would also like to mark the third and fourth stage. So why not? I want one more paper for this. So let me just take one additional seat. Okay. So I will just add a page. It's okay. Yeah. Okay. So this was the invagination of developing lung, stage 1 and stage 2. Moving on to stage 3. Stage 3. And then comes the final stage 4. Okay. Got it, my dear students? Now the lung has developed more, as you can see. Yeah. Okay. And the outer covering should be made like this. Is it okay? So here what happens in this stage, again you can see, you can just okay. So here now this is the laryngotracheal tube. This is the developing lung. As you can see, this developing lung is traversing from the medial side through root of lung. What is this? This will be the root of lung. And subsequently, next stage of development after this, the final lung will be formed. Now the lung is completely formed. Is it okay? Now, my dear students, are you understanding more? Now see, the lung has been formed. So I am using this bluish color for the lung. This will be the complete lung being formed. Got it? The lung is developed, and this is now completely enclosed by two-layered serous membrane, So now we will have two-layered serous membrane, and for better understanding, I will use two colors. So let me use a two colors. So I will just, one is closely adherent and the other will be so I will use it with the two colors. Don't worry, I will use two colors so that you can differentiate between 2. Okay, so we will have here, this will be the inner aspect, this will be the visceral layer of the serous membrane, which will be adherent, and the outer one is the parietal. So here you can just label it, this is the one layer and this green color is the other layer. So this is the visceral pleura and this is the parietal. This is the parietal pleura, my dear students. Is it okay? This is the parietal pleura. Yeah. And the space which is lying in between the visceral and the parietal pleura, this space is the pleural cavity. If you want, I can say the pleural. This is the lung which is formed on either side in the lateral compartment of thoracic cavity. So you can just use this another color for this pleural cavity. This is the pleural cavity. Got it? This is exactly the pleural cavity form. So this is the steps to understand how the development of the pleural cavity happens. Okay, here also if you want, you can mark this inner layer with that of the violet pink color and the outer with the green color. Is it okay? So this is how we have got the formation of the two layered serous membrane of the pleura, the inner visceral, the outer parietal, and the space line between both is the pleural cavity. Got it? So we have understood about the 4 steps and we are knowing the invagination of developing lung into the closed serous sac. Got it? Now thereafter, let's talk about the pleura. So we have done with this. Now after making these two diagrams, I just want you to know about the pleura. So if I talk about the pleura, it is a layer which is similar to that of a peritoneum serous membrane, which is lined by flattened epithelium, and a particular name is given to the flattened epithelium, that is called as mesothelium. What is it called as? It is called as mesothelium. So what is pleura? Please note down, the pleura is I just want a darker shade. Yeah. Yeah. So the pleura is actually a serous membrane which is similar to like that of the peritoneum, and this serous membrane is lined by flattened epithelium which is called as mesothelium, is lined by flattened epithelium termed as mesothelium. Now, basically, what is the function of this inner lining epithelium? It will secrete a watery fluid which will lubricate the lung surface, and this fluid is called as the serous fluid. So secretes a watery fluid, and this watery fluid has the function of lubrication. This fluid is called as serous fluid. This fluid is called as serous fluid. So here also, if I'm talking about this important structure, so here also we can see, let me just mark here, just a minute. If you will see this image, you can mark this two pleura. So you can see here, this is the visceral pleura and this is the parietal pleura. So we have got the inner one is the visceral pleura. So this inner layer is the visceral pleura. As you can see, we can use this as the visceral pleura, and the outer one is the parietal pleura. The outer is the parietal pleura, and the space which is lying in between these two structures, the space which is lying is the pleural space which contains the pleural fluid. Very nicely you can appreciate also in this diagram. in between these two space. So basically this is the parietal pleura, this is the visceral pleura, and the space which is lying between these two, which is shown with a portal space, which is seen here. This space, which is the this space, if you will talk about this space, is filled with the this pleural space is filled with the fluid, and this space is containing the pleural fluid, which is called as the pleural cavity. Okay, so done with this. Okay, my dear students, so we have done with the pleura. Now moving further, now it is important to know the layer. So as I have told you, if we are talking about the layer, I would like to, we are already knowing about the two layers of the pleura. We are knowing about the visceral layer and we are knowing about the parietal layer. So basically in these two layers, I would like to elaborate that what is the unique function. For example, firstly, let me, layers are two, as you know. Let me just elaborate one by one about each layer. The visceral pleura. Actually, the visceral pleura is also called as pulmonary pleura. It is also called as pulmonary pleura. And the other one is the parietal pleura. Okay, we have got two layers, the pulmonary and the parietal pleura. Done with this. Now it's important, what is the, so basically if I talk about the visceral pleura, it is the adherent to or covers the lung surface except at the hilum and along the attachment of pulmonary ligament. So let's talk about visceral pleura firstly. So let me talk about the visceral or the pulmonary pleura firstly. If I talk about the pulmonary or visceral pleura first, so let me tell you about the important features. So when I'm talking about the important features, this visceral pleura covers completely the lung surface. So it covers the surface of lung except at the hilum and along the attachment of pulmonary ligament, along the attachment of pulmonary ligament. Okay, now it, if I talk about other important, this was the first important features, and if I talk about other important features of this visceral or pulmonary pleura, it also extends into the depth of fissures of the lung. So it extends into depth of fissures of lung. And the other and the third most important point which you should know about the visceral pleura or the pulmonary pleura is that it is quite adherent to the lung surface. It is difficult to separate it. It is quite adherent to the lung surface. The third important point is it is formally adherent to lung surface. So when I am using the word firmly adherent, so it's not easy to separate the visceral pleura from the lung surface. These are the important points about the visceral pleura. Now we have to know about the other layer, that is the parietal pleura. These are three important points about the visceral pleura. Let's talk about the parietal pleura. So when I talk about the parietal pleura, it is thicker than the visceral pleura and it lines the walls of the pleural cavity or the thoracic cavity. So let's talk about parietal pleura. It is thicker than visceral pleura and lines the walls of, and it lines the walls of pleural cavity. Got it? Okay. Now we have done with this. Now let's talk about, actually if I talk about the description, for the purpose of description of the parietal pleura, it is actually according to the surface where the parietal pleura is attached, it is divided into four parts. It is called as costal pleura, mediastinal pleura, cervical pleura, diaphragmatic pleura. So it is important that you should know the parietal pleura is having four parts. Okay, so let's also know about that. Division. So again, the subdivision of the parietal pleura, we have got the cervical pleura, we have got the cervical pleura, we have got the costal pleura, we have got the mediastinal, and we have got the diaphragmatic pleura. One by one, I am going to explain each of it. Okay, one by one, I am going to explain each of it, the attachment. So basically, I would also like to make a diagram in which I will show you the parts of the parietal pleura, and I will also show you the recesses, costodiaphragmatic recesses, the recesses in relation to the pleura. So let's subdivision of the pleura. So the parietal pleura is divided into, so parietal pleura is divided into following parts. Okay, it is divided into following parts. And what are the parts? We have got following four parts. What are these? We have got costal pleura. We have also got diaphragmatic pleura. We have also got mediastinal pleura. We have also got the cervical pleura. These are the parts of the pleura which you have to understand. Okay, so one by one I will explain each part. Then we will draw a schematic diagram in which we can understand the subparts of the parietal pleura, and I will also show you the location of costodiaphragmatic recesses. Okay, so let's describe one by one. So firstly, I would like to describe the costal pleura. So please write down the heading. So the first part is the costal pleura. So, by the name only, it is clear that this pleura, this part of the parietal pleura, will line the inner surface of the ribs and the costal cartilages. So, basically, it lines the inner surface of the thoracic wall. And we know the thoracic wall is made of ribs and the associated costal cartilages and the intercostal space. So, inner to that. So, this is attached as a thin membrane, which is exactly, if I talk about it is attached on the inner aspect of thoracic wall, which is consist of ribs, the costal cartilages, the intercostal space, to which it is loosely attached by a thin membrane of loose areolar tissue, which is called as endothoracic fascia. And basically, if I talk about the endothoracic fascia, it's very easy to separate the endothoracic fascia from the thoracic wall. So exact location of costal pleura will be in the inner aspect of thoracic wall. So where it lines? So let me first tell you about the costal pleura, a very important topic. My dear students, are you understanding? I will just check with the students. If they have got any doubt, they can ask me. Okay, my dear students, let me know. Okay. If any of the students is not understanding anything, please let me know. It will be good if you get your doubts cleared right itself when the session is going on. Okay. Costal pleura, it lines the inner surface. It lines the inner surface of the thoracic wall. If I talk about thoracic wall, it is consist of ribs. It will be consist of costal cartilages, and it will be also consist of intercostal spaces associated to which it is attached. So it is lining the inner aspect of thoracic wall, and it is also attached to the thin layer of loose areolar tissue, that is, it is also it is attached to that of endothoracic fascia. Okay, this is about the costal pleura. Now coming to the diaphragmatic pleura. Now again, if the word is diaphragmatic, what do you mean? Diaphragm is lying in the lower inferior aspect, so where it will be attached. So that is clear by the name itself. When I am using the word diaphragmatic pleura, what does it mean? It covers the superior surface of the diaphragm. Where it will be attached on the superior aspect of the diaphragm, the diaphragmatic pleura will be attached. So it covers the superior surface of diaphragm. It covers the superior surface of diaphragm. Now, if I talk about quiet respiration, when the normal respiration is going on, the costal and diaphragmatic pleura are in opposition with each other, okay, below the inferior border of the lung. So that is an important point. When I'm talking about the quiet respiration, both of this layer, that is the costal and diaphragmatic pleura, is actually lying in opposition to each other along the inferior border of the lung. This is a noteworthy point which you have to know. Okay. Okay, so we have already written about the costal pleura, and we have also talked about the diaphragmatic pleura. So you can just write down here again, diaphragmatic pleura. Both the costal and diaphragmatic pleura are lying in opposition to each other below the inferior border of lung. Now, thereafter, we'll talk about the cervical and mediastinal pleura. So, we have done with the costal and diaphragmatic pleura. Now, we will talk about the mediastinal pleura. So, when I'm using the word mediastinal pleura, what does that mean? It will be attached to the mediastinum. And what is mediastinum? Mediastinum is actually the space which is actually lying between the two lungs on either side. So, it is lining the corresponding surface of the mediastinum and mediastinum, and forms its lateral boundary, which is very important for. So basically, if I talk about the mediastinum pleura, it is reflected over the root of lung. It is reflected as a cuff over the root of the lung and becomes continuous with that of the visceral pleura. So there are two important points about the mediastinal pleura. The first point is, and then we have to know about the second point. Mediastinal pleura lines the corresponding surface of mediastinum. Actually, after completing the topic of lung pleura, I will come to the next topic, that is mediastinum, which is a very important topic, as the content of mediastinum is a very important enumeration questions for your viva examination and for your theory papers. So surface of the mediastinum and forms its lateral boundary. Okay, now mediastinum pleura is reflected as a cuff over the root of lung and become continuous with the visceral pleura. And it becomes continuous with the visceral pleura. Is it okay, my dear students? So now we are knowing about the diaphragmatic pleura, we are knowing about the costal pleura and mediastinal pleura. What remains, the last pleura which I have to explain is the cervical pleura, which we have studied also in the topic of suprapleural membrane. If you remember the first class, the substance fascia, there I have told you the substance fascia and suprapleural membrane is giving support to the cervical pleura. Now coming to the next pleura, that is the cervical pleura. Okay, so when I talk about the cervical pleura, it is actually the upper dome part of the parietal pleura which extends into the root of neck. An exact location of cervical pleura is approximately 1 inch above the medial end of the clavicle. So please note down this cervical pleura. It is dome shaped dome of parietal pleura or upper part of parietal pleura. Okay, it extends into the root of neck, extends into root of neck about 1 inch, about 1 inch, that is corresponding to 2.5 centimeters above the medial end of clavicle. Okay, now done. It is actually important for you to know that exactly, if I talk about, it is important that it is important that it is also giving it is also overlapped by the suprapleural membrane. So basically it is very important for you to note down the location of cervical pleura while penetrating any anesthetic needle here, that what is the location. So the location of the cervical pleura is 1 inch above the medial end of the clavicle, and exactly 1 inch above the medial end of the clavicle, and approximately 2 inches, and 2 inches, that is 5 centimeter above the first costal cartilage. Why this is important? So that you, when any anesthetic needle is penetrated, why this is important? Because when any anesthetic needle is penetrated, it is not leading to the injury of the pleura of the lung. Okay, and it is overlapped by, if I talk about cervical pleura, it is overlapped by or supported by suprapleural membrane. And what is the other name of suprapleural membrane? In the first class, I have told you substance fascia, which is degenerated tendon of scalenus minimus muscle. Okay, this is an important point which you have to note down. I also want you that it's important that you should also know about the relation of cervical pleura. So please write on the heading, relations of cervical pleura. Okay, till now, okay, any of the students have got any doubt, please ask me. Let me just check with the students. Okay. Okay. So write down the heading, relations of cervical pleura. Relations of cervical pleura. Got it? Relations of cervical pleura. Okay. Let's write. So relations of cervical pleura is as following anteriorly. Anteriorly, if I talk about anterior aspect, the cervical pleura is related with the subclavian artery and scalenus anterior muscle. So anteriorly, it is related with subclavian artery and scalenus anterior muscle. Got it? Now coming to posteriorly. If I talk about the posterior aspect of posteriorly, posterior the cervical pleura is related to the neck of first rib and structures in front of it. So neck of first rib we already know, the chain pulling van we have already talk about that. And on the lateral aspect we have got laterally, on the lateral aspect it is again having the scalenus. So here if I talk about lateral aspect we have got scalenus medius muscle. And if I talk about medial aspect or medially, on the medial aspect we have got the great vessels of the neck, great vessels of neck. We have got the great vessels of the neck. So these are the important relations of cervical pleura which you have to know. You can't skip this topic. This is very important. Now, till now we have discussed the pleural cavity formation, how the serous sac was again formed as a double layered serous layered structure that is visceral, which has got visceral and the parietal pleura, and the location of pleural cavity and how this embryologically development happens. We have also talked about the parts of the parietal pleura, and we are knowing the relation of cervical pleura. So now the next topic is to know about the pulmonary ligament. So basically when we are talking about the pleura at the level of the root of lung, it is similar. So when you I will make a diagram for it, and you can see, you just imagine that there is an overcoat and the wrist is there. So the overcoat will have a sleeve. So the sleeve which is hanging over the wrist, the overcoat sleeve which is hanging over the wrist, is the pulmonary ligament and the structures. The wrist is actually the structures going in and out, that is the root of lung or root structures. So the root structure will get a space to expand because of the presence of pulmonary ligament. So pleura surrounds the root of lung. So what is this? If I talk about the pulmonary ligament, is the part of pleura which surrounds the root of lung, similar to the cuff of jacket around the wrist. Okay. So basically it extends downward. If I talk about this pleura which is extending downward as the pulmonary ligament. So the pulmonary ligament extends from the root of lung as far down as diaphragm, towards the diaphragm, between lung and the mediastinum, between lung and mediastinum. Okay. So exactly it is, if we talk about this pulmonary ligament, it is filled with if I talk about pulmonary ligament, the fold of pulmonary ligament contains lymphatics, and it contains few of the loose areolar tissue. So it contains loose areolar tissues, and it contains lymphatics, few lymphatics. Actually, pulmonary ligament is extending from the root of lung. So the root of lung, if I'm talking about the root of lung, it will contain the bronchus, it will contain pulmonary arteries, the bronchial arteries. All these structures will be lying in the root of lung. So basically, to understand, I will also tell you about the function of pulmonary ligament. Before that, I just want you to make a schematic diagram showing the structures forming the root of lung and that of the pulmonary ligament. So yes, before that, I just want you to show this image. Okay, this image will be helping you to understand the pulmonary ligament. So here in this diagram, you can see this structure which I am highlighting with the green color. This structure is the pulmonary ligament. This is right pulmonary ligament, my dear. And what you can see inside this pulmonary ligament, which is extending downward as a fissure lying between that of the mediastinum and that of between the lung and the mediastinum, going downward towards the diaphragm. And what all it contains? It contains following structures: contains the pulmonary veins, the branches of bronchus, and that of the artery, pulmonary artery. Now I have got two diagrams. This is showing you the right pulmonary ligament. I want you to show the left pulmonary ligament. So here we have got another image where you can see the left pulmonary ligament, my dear students. Again, you can appreciate here that this is exactly the extent of the left pulmonary ligament. Okay, so here we will have few. You can see the pulmonary arteries, the bronchus, the pulmonary veins. All these are the root of lung. Okay, now we can also make a diagram for it. So let's make a diagram for it. We have seen this pulmonary ligament attachments, and I just want you to make showing you pulmonary ligament. Make a diagram, pulmonary ligament and root of lung. Pulmonary ligament and root of lung. So we have to make a diagram showing pulmonary ligament and root of lung. Okay, pulmonary ligament and root of lung. Let's make a diagram showing this. Okay. Let's make this schematic diagram. Okay, let's make a diagram for it. So basically, actually I told you the pulmonary ligament is like a jacket, cuff of a jacket around the wrist. So we will make like that. So we will make like that. I will firstly make a jacket cuff. Is it okay? Yeah. Inside I have to make the structure. So I have to make structures. I will make pulmonary arteries. I will make pulmonary veins. Okay, so here we will use the red color for the pulmonary veins. Why? I will explain that. This actually you must be knowing also. Why is this color change? Actually, generally what happens, we make arteries with red color because it contains more of oxygenated blood, and we make veins with blue color because it contains more of deoxygenated blood. But the reverse happens here. Why? We will see that if we are talking about the pulmonary arteries, so let me first make, this is blue color vein, this is blue color artery, sorry, pulmonary arteries. So basically pulmonary arteries, pulmonary trunk will divide into pulmonary arteries. This pulmonary trunk via pulmonary arteries will carry deoxygenated blood from the right ventricle of heart to the lungs, where oxygenation of the blood happens, and the blood is returned via pulmonary vein into the left atrium via pulmonary vein. So we will have the pulmonary veins carrying oxygenated blood. Okay, that is a very important point for you to understand. And this is the bronchus, or we can use this color as the bronchus color. Now please label it. This is the pulmonary artery. Okay, this is the two pulmonary veins shown in red color because containing oxygenated blood, and this is the bronchus, which is having rings, cartilaginous rings. Now this is surrounded by, if I talk about this, I would like to highlight about the pulmonary ligaments which is surrounding it. This is a double layered. So basically you can, this cuff which I am making, this cuff which I am making is the pulmonary ligament. Got it? and all other structures which you have drawn can be highlighted with gray color. Got it, my dear? So this structure which is shown here is the pulmonary ligament. Okay, done. Now, my dear students, so why this pulmonary ligament is loose and it is extending downwards? So it is providing dead space. It is providing a dead space into which the pulmonary veins can expand during increased return, during increased venous return. Okay, that is one of the its important function. The other is it allows descent of root of lung with the descent of diaphragm which is happening during inspiration. So these are two functions of pulmonary ligament which you have to note down, which is quite clear by making this diagram also. So please note down the function of pulmonary ligament. So the next heading is function of pulmonary ligament. Function of pulmonary ligament. The function of pulmonary ligament is two important functions the pulmonary ligament has to perform. The first function is it provides dead space for the expansion of pulmonary vein in case of increased venous return. Provides a dead space. It provides a dead space into which pulmonary veins can expand during increased venous return, for example during exercises and all. The second function will be it allow descent of root of lung. It allows descent of root of lung with the descent of diaphragm. During inspiration process. We know that diaphragm is the principal muscle of inspiration. Now, these are the two functions of pulmonary ligament. Now, we are knowing very important points. We are knowing about the pleura in detail. The other important point about the pleura is to know the surface marking of the pleura. That is very important for you to understand. So let's start with the surface marking of the pleura. So actually, for understanding the surface marking of the pleura, either you can make a diagram and you can add a few notes for it. And surface marking of the pleura is actually, I can tell, in every alternate Viva examination, after every 3-4 students, one students are definitely asked about the surface marking of the pericardium or the surface marking of the pleura. So let's know about the pleura. For understanding the reflections of parietal pleura on the surface of the chest wall, it is actually very important for the surgeons and for the physicians to know about the reflections of the pleura, surface marking of the pleura. So reflections of the parietal pleura can be marked on the surface as the part of cervical pleura. So for that understanding, actually this is an image in which you can see. Generally, if I talk about the surface marking, it is done on a cadaveric uh, uh, cadaver, which is kept as our first teacher on the dissecting table in supine and prone position, though two cadavers are there. And then either you can get surface marking of kidney, surface marking of any nerve, any artery, and lung, pleural, and the pericardium, like this question comes. So basically you have to know about so basically here few markings. Xiphoid process has been marked, as you can see here. Also the mid clavicular line, the axillary line, and the ribs, as you can see, the 6, 7, 8, 9 ribs, and the chest has been shown to you. So this on this body only, on the cadaveric body only, you have to mark, and you have to take a chalk and mark firstly you have to pay namaskar. You have to give gratitude to the your first teacher, that is the cadaver, and then you have to start with the process of surface marking. So the knowledge of reflections of parietal pleura can be asked, and it is a very important point for the clinicians and the surgeons. So the reflection of parietal pleura can be studied by following. So I would like to tell you one by one. So you have to understand firstly the cervical pleura. So the surface marking of the pleura, the first point which you have to know, we will make a diagram also. The first point which I want everybody to understand is about the cervical pleura. Actually, I will tell you like cervical pleura marking, then I will tell you about costomediastinal line of pleural marking, then I will tell you about costodiaphragmatic line, and then the posterior line, that is costovertebral line. So we can understand the surface marking of pleura as the 4 points. Okay, so we will have to know about cervical pleura marking. Then we have to know about anterior line of pleural reflection, that is also called as, if I talk, that is the anterior, or which is called as costomediastinal line of pleural reflection. Then we have to also know about inferior or costodiaphragmatic inferior or costodiaphragmatic line of pleural reflections. Then we have also got the posterior or the costovertebral line of pleural reflection. So we will study stepwise the whole of this pleura. Okay, any students, if they have got any doubt, they can ask me. Okay, my dear students. Okay, so let's note down. So firstly, I would like to tell you about the costal pleura. So firstly, cervical pleura. I will start with the cervical pleura. So let's start with the first pleural reflection, which everybody should know is the cervical pleura. Cervical pleura. So when I talk about cervical pleura, it is marked as a curved line. Okay, it is marked as a curved line, which is having the convexity in upward direction, and it is drawn from the sternoclavicular joint. So basically, exactly, if I talk about, it is drawn as an upward line from costoclavicular joint to that of the medial 1/3 of the clavicle. Approximately, that will be the dome of this convex line, which has to be drawn, is 1 inch above the medial 1/3 of the clavicle. So we will draw like that. So let's mark the cervical pleura. So it is marked by a it is marked by curved line. It is marked by a curved line. It is marked by a curved line. Okay, it is marked by a curved line with convexity line, with convexity line upwards, and this curved line is drawn from sternoclavicular joint to the junction of medial and middle 1/3 of clavicle, approximately 1 inch, 2.5 centimeter, that means 1 inch above medial 1/3 of clavicle. So this is how we will draw the costal pleura. So now we are knowing about the costal pleura. Once you understand this costal pleuras and all this anterior and posterior reflections, it becomes very easy to draw the diagram. Okay, surface marking diagram becomes very easy. And the same way you have to mark in the cadaveric body. Got it? Now we have to know anterior, the line that is costomediastinal line. Actually, in the anterior line, when I want to draw about the surface marking of the pleura, there is slight difference on the right and the left hand side. Why? Because in the left hand side, there will be cardiac dullness. There will be presence of heart. So let's now the next step is to know. Okay, so next one is to know. I will just like to write here. Second point is the anterior or costomediastinal line of pleural reflection. Okay, so when I want to describe this, there is 2 points I will write, the on right side, and then I will separately write on the left side. So when I'm talking about right side, okay, on right side, it is it okay? This is on right side. So when I'm talking on the right side, it extend downwards. So we have made the cervical pleura on either side. From there, it extend downwards on the right side medially from the right sternoclavicular joint, and then it will go to the midpoint of the sternum, and then it will go and descend downward vertically up to the xiphisternal joint. So basically, it will go towards the xiphisternal joint downwards in the right side. So let's talk about the right side. So on right side, it extend downwards and medially. It extend downwards and medially from right sternoclavicular joint to midpoint of sternal angle, and then descend, and then vertically descend down, vertically descend up to midpoint of xiphisternal joint. Got it? So this is the right side, how we are extending the costomediastinal line of pleural reflection. What I told you, slightly on left side it is different. Why? Because I will tell you, left side what happens, there is heart. So on the left side, so on left side, it extends downwards and medially from the left sternoclavicular joint to the midpoint of sternal angle, and then vertically it goes up to the level of fourth costal cartilage, and thereafter it will be extending to reach the sternal margin of the sternum, and it will go towards the sixth costal cartilages. Actually, this happens why? Because there is heart on the left side. So first initial part is similar. On left side, it extend downward, it extend downwards from left sternoclavicular joint, to midpoint of sternal angle, okay, this part is and then it will descend down, and then descend down till the level of fourth costal cartilage, descend down up to the level of fourth costal cartilage. Okay, up to the level of fourth costal cartilages, it will then arch outward. Thereafter, it arches outward. Thereafter, it is arching outward as it will arch outward to reach the sternal margin of the sternum. Sternal, it will arch outward. So basically, it will arch outward. It will arch outward to reach sternal margin of sternum. And short distance it travel to the level to reach the costal. So after that, it will traverse a short distance, and it will reach the lateral aspect to the level of sixth, and then it reaches the level of sixth costal cartilage. Okay, so that means from the level of fourth costal cartilage, when it is descending down, it is arching outward and laterally, and it will reach the level of sixth costal cartilage approximately 3 centimeter from the midline. So approximately 3 centimeters from the midline. 3 centimeters from midline. Okay, so basically why there is a gap in the middle part and in the left side, that is the area of heart. So that is the area of the heart which we have to arch there at that level in the left hand side. So this is exactly the difference which lies on the right and the left hand side. So got it? So only I have explained it separately. Only I have explained separately the right side and the left side of anterior extent of costomediastinal line of pleural reflection. Now, done with this, now we have to know. So we will make a schematic diagram also. Before that, I just want you to know about the third important point. That is, also you have to know about the inferior costodiaphragmatic line. Inferior costodiaphragmatic line of pleural reflection. Got it? So here also the reflection is slightly different on right and left side. So firstly, you have to know on right side. On right side. So it starts from, till now we have seen that in the right side it was descending till the level of Ziffy-sternal joint midpoint, and the right side, in the left side it was going towards the level of 6 costal cartilage 3 centimeter from the midline. So on right side, the line starts from Ziffy-sternal joint or behind xiphoid process, and it will start from Ziffy-sternal joint or behind the xiphoid process and crosses the eighth rib in mid-clavicular line, 10th rib in mid-axillary line, and 12th rib at the lateral border of erector spinae muscle, and 12th rib at the level of, at the lateral border of erector spinae muscle. Okay, exactly, this will be 2 centimeters. If I talk about the level at the 12th rib at the lateral border of erector spinae muscle, this will be 2 centimeter lateral to the spine of 12th thoracic vertebra. 2 centimeter lateral to the spine of T12 thoracic vertebra. So this is the extent of inferior costodiaphragmatic line on the right side, and what will be the extent? So I would also like to use one more paper here so that we can know the entire extent. So we have done about the inferior diaphragmatic line reflection on the right side, and I want you to know also about the left side. On left side. Okay. So when I'm talking about the left hand side reflection, so let's come on to the left hand side. When I'm talking about the inferior diaphragmatic costodiaphragmatic line of pleural reflection on the left side, the line of reflection it starts at the level of, at the sixth costal cartilage level, sixth costal cartilage, at the sixth costal cartilage level, about 2 centimeter lateral to midline. And thereafter the courses similar like right side. What does that mean? That means on the right side, it was starting from the center of Ziphy sternal joint, or the posterior aspect of Ziphy sternal xiphoid process, and then extending eighth rib in the mid clavicular, 10th rib in the mid axillary, and lateral to erector spiny muscle at the 12th rib. That same will be going on to the left hand side, but the starting point will be from the lateral to the sixth costal cartilage. Okay. Now we have done with this. Now we will talk about the posterior. The next is the fourth point is, so let's now know about the posterior line of pleural reflection. The posterior line of pleural reflection is also called as costovertebral line. It is called as costovertebral line of pleural reflection. Got it, my dear students? Okay. Now talking about, so basically what happens, if we talk about this posterior costovertebral line of pleural, it is similar on right and left side. So basically the line will ascend from the, basically the line will ascend now. Now the line of posterior pleural reflection will ascending from the inferior line 2 centimeter lateral. So basically the line will ascend, the line will ascend 2 centimeter lateral to the T12 thoracic vertebra spine along the vertebral column, along the vertebral column to the 2 centimeter lateral to spine of C7 vertebra. So that means inferior, we are knowing, we have already talked about the costodiaphragmatic line, and we have seen it was reaching till the level of the spine of T12 thoracic vertebra laterally. From there it will ascend upward till the 2 centimeter lateral to the spine of C7 cervical vertebra, and after that the costal pleura will become continuous with the mediastinal pleura. So here and after that, from this level, if I talk about this line, the costal and mediastinal pleura will be lying along this line only. So this is how we have to draw a diagram showing the pleural reflections. Okay, so that is very important point. So I will also give you an important point about the rib relation with the lung and the pleura. Before that, we will talk about the recesses. Before that, I want you to draw a diagram. So let's draw a diagram, so a schematic diagram showing the pleural reflections. Okay, so that is very important for you to understand. Okay, my dear students, till now any doubt you can tell me. So step by step I have told you about the cervical pleura, I have told you about costodiaphragmatic, costomediastinal pleura, everything I have already explained you. Now we have to draw a schematic diagram showing the pleural reflections, and I will use a green color for the pleural reflection. So basically before starting to make a diagram, there should be an outline of the thoracic cage. Okay, so for that First thing which I have to make is the, this is the sternum which I have made. Okay, this is the sternum which I have made. This is the vertebra which I will make. Okay, here somewhere I will make the clavicle. Okay, this is the clavicle I have made, and then we will make the ribs. Got it? Then again, okay, first rib is that. Then the other ribs will be made like this. Okay, third rib, just an outline. Fourth rib. Okay, this is just an outline which I am making. Okay, this is just an outline. This is a schematic diagram here. So the numbering should be correct. What is important for you is to know the proper numbering. Okay. Okay, so that is important for you to know. So this is for second, third, and fourth. So this T4 is an important point which you have to mark. Then here, okay. Vertebrae, no? T12. Okay, this will be rib 12. This somewhere here will be the rib 11 also going arching. Got it? Yeah. So now we have to use green color so that we can understand. So I am using this green color so that we can understand this pleural reflection. So firstly, it is important that we should be knowing about the from the above. So it is like this. We have to make green color and we have to use this. So what is this green line? This is the cervical pleura. No, it is dome shaped and having the convexity upward. So this part is the cervical pleura. Got it? I'm using green color. This is the cervical pleura going medially straight down. And then In the right side, it will go till the level of, in the right side, it will go till the level of Ziphisternal joint midpoint. But so let me just mark it. I will use arrows. So this point you have to mark. This is the medial 1/3 of the clavicle. This is the medial point of mandibulosternal joints like this. And also it will be meeting in the midline. No, these two lines will come like this. Okay. But okay, so just a minute. Firstly, let me draw these two. Okay. Now here I just want you to, okay, it is arching till the junction of the, so yes, till the first rib it is going towards that end. So till end first rib it will be going, no? So this is an important point. Okay. Now this arrow will be the, this is the arrow showing you that it is convexity upward, and this is actually this is showing you the midpoint of the sternal angle. So basically, if you want, you can go it more medially. Yeah. So this point is the going towards the, if you want, you can mark it. This line is midpoint of sternal angle. Midpoint of sternal angle. So till now we have marked the cervical pleura. Is it okay? Till now we have marked the cervical pleura. This is the sternoclavicular joint which we have marked. This is the sternoclavicular joint. Okay, I'm taking it as the point of so sternoclavicular joint. So we know that above the sternoclavicular joint, so we will have actually from 2.5 centimeter 1 inch above the sternoclavicular joint, and arcing above the medial 1/3 of the clavicle and going towards the junction of the middle and the medial part, as you can see here. So this is a very important point which you have to understand. So when I'm talking about the cervical pleura, so this part is the cervical pleura. Okay, this part is the cervical pleura. If you just want to know, this part is the cervical pleura. And as I told you, cervical pleura is actually drawn from the sternoclavicular joint to the junction of medial and middle 1/3, medial and middle 1/3, and half inch above the medial 1/3 of the clavicle. So it is lying above the clavicle. Very nicely, you can see also this point is the clavicle. So it is lying above the clavicle, my dear. It is lying above, approximately 1 inch above the clavicle, 1 inch above the clavicle. Got it? Okay. So now 1 inch above the clavicle, as you can see, if you want, you can make it more arched. You can either make it more arched or you can make the clavicle more down. That is another way. So this is the clavicle, this is the clavicle, and it is arching above. This is the clavicle. Got it? This part is the clavicle. So you can clearly see it is above the clavicle, junction of medial and middle 1/3. Got it? Now in the right side, if you will see this right side, it is going at the level of midpoint of Ziphisternal joint. So that is also important for you to mark. So again, I have to make a red dot here, and this point is Ziphisternal joint. This is the midpoint of Ziphisternal joint. But as I told you, this is not the case on the left side. Why? Because left hand side, it will arc from the level at the level of T4. So basically, it is arcing. So T4, this is the fourth rib, and this is fourth rib, you can say. So basically, it's you can just mark 4 also, because you are getting confused with this. So you can mark fourth rib. Okay, this is the fourth rib. Okay, and from that level, you can see this is the level of fourth costal cartilage. It is arching more laterally, as you can see. This is arching more laterally from the level of fourth costal cartilage. You can mark this dot point from this level, and it will arc till the fourth. This is 4th, this is 5th, and this is 6th till this level. Now I will okay, again this point. So, and please label this points, okay, so that no confusion. This is the level of 4th costal cartilage. This is the level of 4th costal cartilage. Okay, I will use a thinner pen because this is the level of 4th costal cartilage. 4th costal cartilage, and this is the level of 6th costal cartilage. This is the level of 6th costal cartilage. So you can see it is arcing laterally. Okay, it is arcing laterally. Okay, I'm just, so basically I'm just using green color to mark it. Okay, I am just using green color to mark it. Okay, so after this, if you want, we can take, I think, brighter green color is good, no? Brighter green color. Now is it okay? Yeah. Now in the right side, now it will be traversing in the 8th rib and the mid clavicular, then it will come to 10th, and then it will traverse to the 12th. So basically then you have to draw a line towards 8th rib, okay, and then towards the, approximately you can just mark this as the 10th rib, and then going towards the 12th rib like this. Okay, in the left hand side it will start from the 6th, 7th, 8th and all. 7th, okay, just a minute. Here you can just, okay, laterally, and then coming to the level of 12th rib like this. You can just mark it with a pointer, like this is 8th and this is 10th. Okay, here also you mark it, it's 8th and this is 10th. 12th is already written. If you want 7th, 8th, this is also, this was 7th, 8th, and this is 8th, this is 8th, this is 9th and 10th, this is 8th, so this will be 9th and 10th. Like this you mark, it's better. Got it? The important point is the marking. Don't worry about that. Okay, now I will just use green color to mark. Got it? Now you have to mark this point so that it is better for you to understand. So basically this is 10th rib. This is 10th rib level. This is 8th rib. Here also this is 8th rib and this is 10th rib. This is 8th rib and this is 10th rib. 12th rib on either side I have already marked. 12th rib on either side I have already marked. No doubt about that. Okay, 12th rib. So 12th rib point also you can mark here. This is the 12th rib point. This is lateral to erector spinae muscle. This is rib 12 and it will be lateral to erector spinae muscle. Lateral to erector spinae muscle. Got it? Lateral to erector spinae muscle. Got it, my dear students? So we are done with this. So this is anterior view only. So from here it will go again upward. So this is an important point which you have to know. Okay. So this is 12th rib, lateral to erector spiny muscle. As you can see here, this is exactly the 12th rib. This is exactly the 12th rib, and this is lateral to erector spiny muscle. You can, if you want, you can mark it also. This is also lateral to erector spiny muscle. And these are 12th rib. These are rib 12. No? These are rib 12 on either side. This point. Okay. So this is this green color line which I have made. If you want, we can darken it more. This green color line which we have made is the pleural reflection. This is the pleural reflection. Okay. If it comes and you draw a diagram like this, it should be not beautiful, but it should be anatomically correct. So basically the important points which I have marked, like sternoclavicular joint, midpoint of sternal angle, level of fourth costal cartilage, sixth costal cartilage, eighth rib, 10th rib, rib 12, 12th rib, lateral to erector spiny muscle, mid. So all these which I have marked, this is showing you the points of the pleural reflection which you have to make. This is very, very important diagram. And it is very important that you make the diagram like this. And it's not difficult. If you are knowing the points, it becomes easy for you. If you want to use gray color, you can use for the ribs, but I think the green color line and that their points and the level is important. Okay, now a noteworthy point is that the if I talk about the rib crossed by the inferior margin of lung, is actually we see the inferior aspect of the lung. It is more horizontal, and it is important that you should be knowing that inferior margin of the lung and the inferior aspect of the pleura is crossing the ribs at which level. So that correlation is also important. So please write down, then we will come to. So you just mark an important point. Ribs crossed by inferior margin of lungs, pleura. That is important for you to know. Rib crossed by inferior margins of lung and pleura. So inferior, this has to be compared also. So basically the rib, this is important for you to know the rib crossed by. So here you can see in one side you can mid clavicular line, mid clavicular line. So you can just write in mid clavicular, in mid clavicular, mid axillary, and lateral to erector spiny muscle, lateral to erector spiny muscle. So that means A point, B point, and C point. I want to compare that. As I have told you, the inferior margin of the lung is more horizontal as compared to the pleura. So here we have to know the ribs crossed by inferior margin of lung. And so here 3 points are there which you have to know: in the mid clavicular line, in the mid axillary line, and lateral to erector spiny muscle. So at these 3 points, so write down inferior margin of lung and inferior margin of pleura. So if I talk about inferior margin of lung, in the mid clavicular line, it is crossed by sixth rib, it crosses sixth rib, it crosses mid axillary line, 10th rib, and 8th rib and the 10th rib in the lateral border of erector spiny muscle, and it will cross 10th rib, 2 ribs add on for the pleura. So this is what you have to understand. Okay, so this is an important point which everyone should understand. Okay, if I'm talking about the ribs crossed by inferior margin of lung and pleura, there is 2 ribs difference. Inferior margin of lung crosses 6th, 8th and 10th rib in mid clavicular, mid axillary and erector spiny line. That means at the level of A, B and C. And if I'm talking about inferior margin of pleura, 8th, 10th and 12th rib at the level of mid clavicular, mid axillary and lateral to erector spiny muscle. So we have done with this. Next is to know about the pleural recesses. Okay, so when I am talking about pleural recesses, Normally, there is a potential space between the visceral and the parietal pleura, which is called as the pleural cavity. But at certain area, this space is expanded, and there are two important recesses of the pleura, which you have to know. One is costodiaphragmatic, another is costomediastinal recesses. Okay. So that is an important point to be known. Okay. So that is very, very important point for you to understand. I think that we have made this diagram, and pleural ligaments also I have made. Okay, that, I have told you about the plurals, and here I have explained you about the recesses. So that is an important point which everybody should know. Okay. So actually, I would like to make a diagram for recesses also. Okay, let's see this. Done, my dear students. Now we will talk about the recesses. So two important recesses are there, which you have to actually subdivisions of the parietal pleura and recesses diagram is important for you to understand. That is very important for you to understand. Before that, let's talk about the recesses. So recesses are, so normally if I talk about the space which is lying between the potential space which is filled with the serous fluid in between the parietal and the visceral layer is the space that is pleural cavity. But at certain area, this space is expanded, forming the pleural cavity recesses. So the expanded region of pleural cavity is called pleural recesses. Okay. And what are they? So we have got two pleural recesses. One is costodiaphragmatic recesses, which will be present in both right and left side. And we have got costomediastinal recesses, which will be again present in the right and left side. Got it? Okay. So my dear students, if you have got any doubt, please let me know. Okay. Now, so in addition to this important recesses, okay, that is costodiaphragmatic and costomediastinal recesses, we have got three more recesses, right and the left, retroesophageal recesses and infracardiac recesses. In addition to this, we have got three more recesses. We have got right and left retroesophageal recesses. These are minor recesses. Actually, if I talk about this recesses, this is lying in between. This is actually formed by the reflections of mediastinal pleura lying posterior or behind that of the esophagus, and the other one is infracardiac recesses. Infracardiac recesses is lying beneath the inferior vena cava, sometimes are in beneath the it is a recesses of the sac which sometimes extend beneath the inferior vena cava. So that is the important one. So costodiaphragmatic recesses is very important recess. It is located inferiorly. It is between the costal and diaphragmatic pleura. So basically, let's see the costodiaphragmatic recesses. So in this diagram, I want you to show the costodiaphragmatic recesses. See here. So this is the costodiaphragmatic recesses, the space. If you just want to enlarge, you can see the costodiaphragmatic recesses. And this is exactly the recesses which is lying between the, in this diagram, we can see the costomediastinal recesses also. This is costomediastinal. Two recesses are very important. One is the costomediastinal and other is costodiaphragmatic recesses. So when I'm talking about costodiaphragmatic recesses, it is located inferiorly between the costal and diaphragmatic pleura. Okay. So let's note down this. Costodiaphragmatic recesses is located between costal and diaphragmatic pleura. Okay. This recesses is very, very important recesses which we have seen here, and the other one is costomediastinal recesses. So let's talk. So here in this diagram, we can see this is the costomediastinal recesses which we have seen, and this is the costodiaphragmatic recesses. Okay. So already I have told you about the diaphragmatic recesses, which is between the mediastinal pleura and the costal pleura. And if I talk about we have talked about the diaphragm. The costodiaphragmatic recesses is between the costal and the diaphragmatic pleura, and costomediastinal recesses is present anteriorly, and it is located between the costal and mediastinal pleura. So please write down costomediastinal recesses is located anteriorly between costal and mediastinal pleura. So basically it lies between the sternum and costal cartilages. Okay, so we have seen here costomediastinal. In this diagram, we can appreciate costomediastinal and we can appreciate the costodiaphragmatic recesses. Okay, so actually we have got an image showing this, and I would also like to draw a diagram in which you can have the appreciation of the parts of the parietal pleura and the recesses. Also, we can make a simple diagram. This is an easy diagram I want you to make. So can we have a, yes, we can make a diagram here. I just want you to make a diagram showing subdivisions of parietal pleura, and costodiaphragmatic recesses will be evident more anteriorly. That recesses between the mediastinal and that of the costal recesses is the costomediastinal recesses that will be seen in the anterior aspect only. Okay. Now, for that, I would like to make a diagram showing the parts of parietal pleura and that of the costodiaphragmatic recesses. So, write down. So, in this diagram, we can see subdivisions. One more diagram you have to make showing subdivisions of parietal pleura and costodiaphragmatic recesses. So, this simple diagram we have to make. So, for that, I will make a schematic diagram. So, I would like to draw few of the ribs. Both the side. Just an outline. Okay, like this. We have got green color for the outer parietal one. Okay, and we have got violet color for the visceral. See. Okay, and the middle part is the mediastinum. Below we will also have below we will have the diaphragm, and here I will draw a line like this. Okay, so this part. This is costodiaphragmatic recesses. Got it? So here you can label it as the mediastinum. This middle part is mediastinum. This is mediastinum. Got it? And we will have this as the thoracic wall. Let me just connect this. This is showing you the intercostal spaces, ribs. This is the thoracic wall. Okay, these are all ribs, dear. These are all ribs which I have made. These are all ribs, cut section of the ribs, intercostal spaces, the thoracic walls. Okay, so here we will have lower down. This I want to make the diaphragm means. This is the diaphragm. Got it? And this space is the this space is the costo diaphragmatic recesses. This is costo diaphragmatic recesses. Okay, dear, this space. Okay, now the parts of the pleura is also important. So here we can have a dotted line. This is exactly the dotted line showing. Yeah. So this is exactly, yeah. So here we will have the parts. So we will have the parts like this line is, this is the first point. So this first point is showing you the cervical pleura. This is the cervical pleura. Is it visible or not, my dear? This is the first point. This is the cervical pleura. Okay. This part which is lying here, this will be the costal pleura. This is the costal pleura, my dear. Okay, this part which is lying close to the mediastinum, so this will be the mediastinal pleura. This is mediastinal pleura. And this which is lying close to the lower below, this is the diaphragmatic pleura. Got it? So here we have drawn the paths. So we have drawn the paths of the parietal pleura, and we have also seen the location of costodiaphragmatic recesses. Costodiaphragmatic recesses. Clear? So this is how you will draw. So a substantial amount. If you will see, the substantial space will be here. So you can just see this is the substantial space on either side, which I am showing you more substantial spaces. So that means this part is the costodiaphragmatic recesses. This is the costodiaphragmatic recesses. Got it? Okay. So done with this. Now it's important. So we have finished with all the important points. I think after finishing all the recesses, I would like to tell you about the nerve supply and the blood supply and the clinical anatomy. So let's move. So done with this? Yes, my dear, we have done with this. Let's move to the applied anatomy, blood supply and nerve supply. Okay. Okay, so I just want you to show the space which is showing you the radiological image is there, and in this radiological image you can see the yellow color line is showing you. So can you see the yellow color arrow, my dear? If you don't, I can highlight this. Can you see this yellow color arrow? This yellow color line or the arrow is showing you the costodiaphragmatic recesses is actually obliterated. So here you can see the costodiaphragmatic recesses is obliterated, and this is because of the pleural effusion. So pleural, a small quantity of fluid, if the pleural effusion means the fluid is the fluid has collected in the costodiaphragmatic recesses. Costodiaphragmatic recesses. So if there is fluid, any kind of basically this collection of fluid which is obliterating or widening the angle of costodiaphragmatic recesses, and we can appreciate in the PA view of chest X-ray. This is the radiological appearance of pleural effusion. Okay, so this will be the first indication of pleural effusion that is routinely examined by chest radiograph. And the site of expansion, it's also important that you should be knowing the site of expansions of these pleural effusion. So the site of expansion of the pleural effusions, which is seen here, can be on following site. It can be on either side towards the root of lung. So it can be on either side in the root of in the root of neck. It will extend. Okay, it will be also seen in the right side, in the right xiphisternal angle, and on either side of costovertebral angle, on either side costovertebral angle. So that means actually the first site is the obliteration of costodiaphragmatic recursus. It can extend into the right side of xiphisternal joint towards the root of lung onto the costovertebral angle. Why this has to be kept in mind? Because for draining or causing any kind of puncture, for draining the pleural effusion, this landmark must be known to you. Now let's talk about the nerve supply. So basically, if I talk about the nerve supply of the pleura, we have got two layers of the pleura. We have got parietal layer, my dear students. We have got the parietal layer and we have got the visceral pleura. Okay, so if I am talking about the innervation of the parietal pleura, the parietal pleura is mainly innervated by, so basically parietal pleura is developed from the somatopleuric layer of lateral plate mesoderm. It develops from somatopleuric layer of lateral plate mesoderm. So it will be having sensitive to the pain, and it will be supplied with somatic nerve. So basically it will have innervation via the same. So basically, for example, if I'm talking about the parts like costal and the peripheral parts, so, or diaphragmatic parts, so it will be supplied by intercostal nerves. It will be getting innervation from phrenic nerves. So mainly the mediastinal pleura and the central part of diaphragms and all covered will be phrenic nerve, and the costal and peripheral part of the diaphragmatic pleura will be from the intercostal nerves. It will be somatic nerves and it will be pain sensitive. Okay, the visceral pleura will have innervation same as the lung. So basically it will have both sympathetic and parasympathetic. So the sympathetic plus parasympathetic will be giving innervation to the visceral pleura from pulmonary plexus. It will form pulmonary plexus, and this pulmonary plexus will be insensitive to pain, and it will be actually parasympathetic will be from the vagus and sympathetic will be from, so sympathetic will be from the source of T2 to T5 thoracic nerves, and parasympathetic from the source of vagus nerve will form the pulmonary plexus and will give innervation to visceral pleura same as the lung. Now coming to the blood supply. So blood supply, if I talk about blood supply of the parietal pleura will be same as the thoracic wall. Already I have talked about the thoracic wall blood supply. So it will be same. Okay. And that will be same. And if I talk about the visceral one, it will be same as the lungs. It will be same as the most lungs. Okay. Now let's talk about few of the clinical anatomy referred pain. If I talk about the referred pain of the pleura, so pain from the central diaphragmatic pleura and that of the mediastinal pleura is referred to the neck and shoulder region, and this is because the skin at this site has got same segmental innervation through a supraclavicular nerve. So basically referred pain from the pleura, mainly from which part of the pleura? The central diaphragmatic and that of the central diaphragmatic pleura and that of the mediastinal pleura. This will have the referred pain exactly towards the neck and shoulders. And why towards the neck and shoulder? So why towards the neck and the shoulder? The reason is this will have same segmental innervation via C3, C4 and C5, and this is via supraclavicular nerves. So basically it is via phrenic nerve. Phrenic nerve has got the root value C3, C4, and so supraclavicular nerve also have the same segmental innervation and innervation by C3, C4, C5. So same segmental innervation is the reason of the referred pain of the mediastinal and the central diaphragmatic pleura towards the neck and the shoulder region. Now, difference between parietal and the visceral pleura, it's very easy to know. So one side you can write parietal pleura and one side you can write the visceral pleura. Obviously this is pleura. Now, so exactly we know that where is the parietal pleura lying and where is the visceral pleura lying, that is known to us, no doubt about that. So that is known to us that parietal pleura lines the thoracic wall and mediastinum. And what about the visceral pleura? It lines the lung, Now, developmental aspect, I have already told you, visceral pleura is developing from splanchno-pleuric layer of lateral plate mesoderm and parietal pleura from the somatopleuric layer of lateral plate mesoderm. So it develops from somatopleuric layer of lateral plate mesoderm. And the visceral pleura develops from splanchno-pleuric layer of lateral plate mesoderm. Now, so that means visceral pleura will be innervated by autonomic innervation, will have autonomic innervation, and the parietal pleura will have somatic innervation. That means parietal pleura will be sensitive to pain and visceral pleura will be insensitive to pain. So that means it is sensitive to pain and it is insensitive to pain. Now, blood supply, lymphatic innervation, everything will be same that of the thoracic wall. So blood supply and lymphatic drainage. Same as thoracic wall, which we have done in the previous session, thoracic wall. And if I talk about visceral pleura, it is having the blood supply and lymphatic same as lung. Same as lungs. So this is the basic difference. So what I have written, this is the basic difference which is lying between the parietal and the visceral pleura. Okay. Now let's talk about few of clinical aspects. So one of it is pleuritis or the pleurisy. So when I am talking about pleuritis, itis means inflammation of pleura. So that means this is the condition of inflammation of parietal pleura. Okay. So inflammation of parietal, clinically it is presented with, actually this pain will be aggravated with the respiratory movement. This pain will be aggravated by a respiratory movement radiates to thoracic and abdominal wall, and commonly the reason of the inflammation of parietal pleura is the pulmonary tuberculosis conditions. Okay, accumulation of inflammatory exudate on the parietal pleura. This will lead to friction which occurs between the two layers of the pleura, and basically you will hear a pleural rub sound when the stethoscope will be placed on the chest wall. So there will be also in the pleurisy and pleuritis there will be pleural rub which is heard because of the friction between the two layers of the pleura, visceral and parietal pleura. Okay. Now the the collection of air, blood, pus is called as hydrothorax. So basically The term which is used basically is the hydrothorax, which is the term used for the pleural effusion. Pneumothorax, air is trapped. Hemothorax for the blood. Pyoempyema, this the pus. So this is the image. So basically, if there is a collection of fluid, serous fluid, as in case of serous fluid collected, and this can have an water collection in the pleural cavity. This is if the water collected is there, that will be a case of pleural effusion or hydrothorax. If there is blood collection in the pleural cavity, that is the case of hemothorax. If there is air trapped in, that is the case of pneumothorax. And if there is pus trapped in, that is the case of empyema. Now, pleural effusion, can see here, if there is a case of pleural effusion. So generally, if I talk about pleural effusion, normally the pleural cavity, if I talk normal pleural cavity, the normal pleural cavity is just containing 5 to 10 ml of serous fluid, okay, which is important for the lubrication. So if I'm talking about this fluid, that is 5 to 10 ml of the pleural fluid, which is important for the lubrication of the layers of the serous and the parietal. So basically this involved a smooth movement, okay, without any kind of friction. So excessive accumulation of fluid in the pleural cavity, if there is an excessive, you can see this is the serous fluid, hydrothorax, water, or a serous fluid, excessive accumulation of fluid in the pleural cavity, of fluid in the pleural cavity, in pleural cavity, is called as pleural effusion. Is called as pleural effusion. Got it? Now, here you can see this image. It is so basically it can be, you can see this is showing you the pleural effusion. This is showing you the pleural effusion, and you can see a whole obliteration of costodiaphragmatic recesses and inflammation of pleura is there. Pleural effusion leads to decrease expansion. It will lead to decrease expansion of lung, which will be on the side of the lung involved. It can be detected with decreased breath sound and dullness. The patient will have decreased breath sounds and dullness at the site of pleural effusion. Okay, at the site of pleural effusion. Now, let's talk about thoracocentesis pleural tapping. So basically, this is a procedure to extract the excess fluid. So this is aspiration of excess fluid. So this process is aspiration of excess fluid in pleural cavity. Okay, so the patient will be in the sitting position. Can you see the patient is in the sitting position? The patient is sitting position and leaning forward. You can see the patient is in sitting position and leaning forward. This is an important position. And usually the needle will be inserted towards the 6 intercostal space. So the patient is in sitting position, leaning forward, and generally the needle, if I talk about the needle insertion which is happening, needle insertion is generally done in the 6th intercostal space in mid axillary line. Okay, so in the 6th intercostal space, and okay, so basically the needle is inserted, and the needle is inserted into the lower part of the intercostal spaces. So basically the needle will be inserting into the lower part of intercostal space. And exactly why it is done here. So the reason is we want to save the intercostal nerve. So basically the needle insertion should be done in a way so that we are not injuring the intercostal nerve. So that is an important point, that the needle will be inserted in such a way that we are not causing injury to that of the intercostal nerve, and it should be done along the upper border upper border of the rib to avoid injury to the intercostal nerves and the vessels. So it will be the intercostal space will be approached towards the lower part, but the direction of needle will be in upward direction. The needle passes successively through the skin, superficial fascia, serratus anterior muscle, intercostal space, endothoracic fascia, parietal pleura, and then reaches the pleural cavity. Actually, ultrasound guided can also be used so that we are not puncturing the visceral pleura or the lung. Okay. The other cases of pneumothorax in which there is accumulation of air in the pleural cavity. Accumulation of air in the pleural cavity. So you can see atmospheric air is accumulated in the pleural cavity, as you can see in the diagram, sucked in. So there is actually spontaneous pneumothorax will happen. As the name suggests, it is spontaneous. So that is happening to because of the reason of rupture of emphysematous bullae of the lung. So that is the reason. So you can see this is a case of spontaneous pneumothorax. Pneumothorax, in that case, you can see this is normal lung, and because of the trapping of air fluid in the pleural space, the collapsed lung has been shown to you. So this is the condition in which the pleural cavity, has got trapping of air, trapped air due to rupture of emphysematous bullae of the lung. Now, it can be closed pneumothorax, it can be open, or the third variety is tension pneumothorax. So, when I am talking about open pneumothorax, what happens in the open pneumothorax? The condition occurs when the stab. So, in this condition, if there is a stab wound, if there is a condition of stab wound which is towards the thoracic wall, and it has penetrated in the pleura leading to accumulation of air, and it is having a communication. So this is stabbed through the thoracic wall having communication. So communication of air is in pleural cavity with that of atmospheric air also. So basically, if there is communication of the air, which due to rupture of emphysematous bullae of the lung, and there is trapping of air in the pleural cavity, is also communicating with the atmospheric air, then it is called as open pneumothorax. Now you can see here, this is a case of closed pneumothorax and this is a case of open pneumothorax. So air is in the pleural sac, as you can see in this case, air is in the pleural sac. Okay, in this case, you can see air is in the pleural sac, but the communication of air is not with the atmospheric air. Here, the air is in the pleural space, but this air is also communicating with the atmospheric air and that of pleural cavity. Both communication is there. The third variety is tension pneumothorax. In tension pneumothorax, what happens? In the tension pneumothorax, this is the third variety. Actually, in this time, the patient inspires the air. Air is sucked into the pleural. Sometimes the clothing or the sucked in with the pleural cavity, and sometimes the clothing or that of the layer of thoracic wall combine to form a valve that seal the air through the wound during inspiration but cannot exit it. Okay, so in this substance, air pressure builds up continuously in the pleural cavity of the wound of the wounded side, and that is actually pushing the lung. So basically it will lead to, it pushes the mediastinum to the opposite side. So this is an emergency condition, that is tension pneumothorax. So tension pneumothorax, you can see the trap, this is inspired air, as you can see, this is not releasing outside, no, and it is getting trapped inside. So sometimes there is clothing or the layer of thoracic wall which will combine to form a valve so that air enters the wound during inspiration but it cannot exit. So this kind of pneumothorax is called as tension pneumothorax. So tension pneumothorax, sometimes in patient when air is, sometime in patient when air is sucked in due to clothing or thoracic wall. Due to clothing or thoracic wall, it forms a valve. It forms a valve so that air enters through the wound but cannot exit. So basically air is not exiting and it is coming inside. So this circumstances will lead to air pressure buildup continuously. This will lead to air pressure. This will increase the air pressure, or air pressure is continuously building up in the pleural cavity. In the pleural cavity. So basically this is an emergency condition, and definitely the air sucked in which has to be released through in the case of tension pneumothorax. Okay, so tension pneumothorax. So you can see this image. In this you can see the closed air in the pleural space which is not communicating outside. Air in the pleural space having communication both outside and inside, and air is trapped inside but unable to the escaping of the air in the expiratory process, that is called as tension pneumothorax. Actually, in case of tension pneumothorax, is characterized by collapse of the lung on the affected side and the compression of lung on the healthy side. So one of the important feature of tension pneumothorax is, if I am talking about the case of tension pneumothorax, one of the important features of tension pneumothorax is two important features clinically you can see in the patient. What is it? Collapse of the lung on the affected side. Collapse of lung on the affected side and compression of lung on the healthy side. Compression of lung on the healthy side. Okay, so this is a very important thing which you have to understand. Okay, so definitely it is important that you have to actually, pleura and pleural cavity is a very important topic for discussion, and I just want you to know that we have finished this topic, and before ending, a quick recapitulation of the session. So what I have told you, that it is important that you should be knowing about pleural reflection. You should be knowing about pleura parts, costal, cervical, mediastinal, and diaphragmatic pleura. You should be knowing where is the costodiaphragmatic pleural recessus located, where is the costomediastinal pleural recessus located. You have to know about the visceral and the parietal pleura. You have to know the reflection, pleural reflection. You have to know about the surface marking. You have to know the parts. You have to know the pleural cavity. You have to know about the blood supply, innervation. So actually all these, and clinical anatomy is also important. The question comes, actually it's very important that you should be knowing about this topic. You have to draw the diagram. What all diagrams is important? Diagrams of the parts of the parietal pleura and costodiaphragmatic recesses, diagrams of surface marking of the pleural reflection is important. And also I have explained you the steps how the two layered how the serous pleura is having two layers, is serous membrane which was single layer, serous sac was there, and how it forms two layers, that is the visceral and the parietal pleura. All these things are highly important. So actually this is very important for your surface marking viva also. And I told you every alternate students, or every 3 4 students in the surface marking, they will get a cadaver, and in that cadaver with the chalk you have to mark the pleural reflection. You have to show the markings for the cervical pleura, the anterior pleural reflections, the posterior, and you have to know about how the ribs level is there in the pleuras, which I have explained at different level, mid clavicular, mid axillary, and that of the lateral to erector spine. All these things are very important. I also want you to pay attention to the clinical anatomy. In the clinical anatomy part, we have discussed about types of pneumothorax, that is closed and open pneumothorax and tension pneumothorax. What is pleural effusion? What is thoracocentesis. What is difference between the parietal and visceral pleura? I have told you the parietal pleura is somatopleuric in development, and splanchnopluric is the visceral pleural development. Splanchnopluric visceral pleura is insensitive to pain supplied by autonomic nerves, and somatopleuric developing the parietal pleura is sensitive to pain supplied by the same as the thoracic wall. Then blood supply innervation has been done. We have also talked about the radiological appearance of pleural effusion. I have also talked about the recesses, costo-mediastinal, costo-diaphragmatic recesses, the inferior, anterior, cervical, posterior pleural reflection. We have talked about pulmonary ligament and the function of pulmonary ligament. We have also talked about the relations of cervical pleura, and we have also drawn a diagram showing the parts of parietal pleura. All the best and keep studying. Again, I will meet tomorrow the same time, 6 p.m. session will be there, and I will explain the lungs. Okay. So, my dear students, if you have got any doubt, please let me know. Okay. My dear students, if you are not understanding anything and you want to repeat me, you can ask me in the following session. No, not exactly tomorrow. I think my session is on 4th June. Okay, today is 1st June and we have completed whole of the pleura and pleural cavities. In the 4th June session, 6 p.m. evening, I will start with the topic of lung, and I will explain all the relations of the lung, and I will explain about the hilum and the bronchus part, about the root part of the lung relations, and also I will talk about innervation, blood supply, and bronchopulmonary segment and clinical anatomy. All the best and keep studying. We'll again meet in the next session. Any doubt, you can directly ask me the doubts in the next session if you have missed out anything. All the best and